Great. Okay, I'll call to order the Green Mountain Care Board's hearing of July 8th, 2024. Hope everyone had a wonderful July 4th weekend. We have one presentation today, which is the kickoff and preview for community conversations pursuant to Act 167. And that will be presented by Marissa Melamed, our Deputy Director of Health Systems Policy, Hillary Watson, our Health Policy Analyst, and Dr. Bruce Hamry, the Chief Medical Officer and a partner at Oliver Wyman, who's been leading the work for the Care Board under 167. First, I'll take up the minutes from June 12th, and I will move that we approve those minutes. Is there a second?
Second.
All those in favor of approving the minutes of June 12th, say aye.
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 Aye. The minutes are unanimously approved. I will also move for the approval of the minutes of.
You're not yet where you can go into this meeting. You can't get on Teams.
And there's a couple of tweaks I need to make real quick.
Sorry, on the phone. Okay, I think we fixed it. I move for approval of the minutes of June 19th, 2024.
Second.
And all those in favor say aye.
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 Aye. And the minutes are unanimously approved. And with that, I'll turn it over to Ms. Melamed, our Deputy Director of Health Systems Policy, to introduce Dr. Hamry and the presentation today.
Hi, good morning, Chair Foster, and thank you. I do not have prepared remarks today, so I'm happy to just turn it directly over to Bruce, who you've all heard from before, but I do want to remind everybody about the schedule of community meetings that we have starting tomorrow, Tuesday, June 9th, and going through the rest of July to August. All of those meetings are posted on the Green Mountain Care Board website with links to RSVPs where you can register for the meetings, get a reminder, put it on your calendar. As well, there is a virtual meeting in early August that you can join. And there will be closed captioning available at the meetings. If people have any questions about the logistics of the meetings, Hillary and I are available to answer those either by phone or email, or if they come up in the meeting today, we are happy to answer to accommodate the most attendance that we can. So that's all I have. Chair Foster, if you want me to turn it right over to Bruce, who looks like he's ready to go.
We might as well also remind people which meetings we have this week. So I believe tomorrow is the meeting in Newport. And I believe Member Holmes and Member Lunge will be attending that with Dr. Hamry and Care Board staff in AHS. And then on Wednesday is the meeting at St. Albans. And if my memory is correct, we have Thursday at Northeastern Vermont Regional. Did I get that right, Marissa?
Yes.
Yes, yep, in St. Johnsbury.
Yep. Okay, so if anyone's on the call and would like to attend those, we'll be at those locations on Tuesday, Wednesday, and Thursday, and they're available on our website. Okay, thank you. Dr. Hamry?
Thank you, Chair Foster. Chair Foster, members of the board, ladies and gentlemen. Today I will show you the ways we have sought to address and solve both the problem of hospital sustainability and the attendant issues of health equity, access, and affordability. The Green Mountain Care Board and the Agency of Human Services have worked for many years to improve the health of Vermonters and to reduce the cost of health care. Our involvement began in August 2023, 11 months ago. We have worked to make this process as transparent as possible, and to that end, as Chair Foster said, we'll begin a series of in-person community meetings tomorrow night and continuing through July. In these meetings, we will present some of our findings and projections for the financial stability of the local hospital together with potential options to preserve and enhance essential health services. After these meetings, we will take the input received from the community and use them to write a final report with specific recommendations at the hospital and county level. As you will shortly see, the financial stability of many Vermont hospitals is in significant jeopardy now, and we expect this to worsen over the next 3 to 5 years. Urgent attention to planning for more modern and effective ways to provide access to affordable health care in ways that are economically sustainable are needed. The winds of change are at gale force now and approaching hurricane speeds. Some changes are underway and must be speeded up. Others must be designed, agreed upon by the parties involved, and implemented. The process to accomplish this will be led by the Agency of Human Services. New payment methods to permit these changes will also be needed. Next slide. Act 167 and our current work was the result of several years of effort by this board and others. It requires you and us to, quote, conduct a data-driven, patient-focused, community-inclusive effort to assist Vermont hospitals to 1, reduce inefficiency, 2, lower or constrain costs, 3, improve population outcomes, reduce health inequities, and increase or maintain access to essential health services. Our work effort is summarized on the right. We anticipate having our report completed by mid-August and available to present subsequently to you at your pleasure. Next slide. Three weeks ago, on June 19th, we presented high-level recommendations for changes in state systems and the policies needed to support hospitals and other caregivers in healing the sick and to identify and treat illnesses at an earlier stage. These measures will reduce harm to the patient and reduce costs to the patient's family and to the state as a whole. Today, I will review in detail how we conducted our process, what Vermonters told us about their experiences of healthcare, including its cost, and their experiences of health inequity. I will show how we demonstrated the impacts, how we estimated the impacts of the traditional measures hospital administrators use to keep their organizations afloat, and what the impact of these might be on hospital survival. Last, we will list some of the many options currently employed by others around the U.S. and in other countries to deliver effective, high-quality health care without the necessary need for bricks and mortar. Next slide. As shown in June, my team and I have listened to over 1,800 Vermonters, including community residents, caregivers of all kinds, hospital executives and boards, and many state agencies, departments, and leaders. This slide has been updated to reflect our conversations with hospital boards in June and additional meetings with various state agencies and associations. Shown are 179 meetings, most of which were 2 to 3 hours in length. Included in the tally are the personal visits I made to each hospital in Vermont and to Dartmouth-Hitchcock Medical Center. The public meetings with Vermonters and providers in each community were transcribed, and the comments shown on the next slide are taken from those meetings. Next slide. These comments and many others made by Vermonters form the basis for many of our recommendations. I call your attention to a few of these comments. The lack of housing is a problem, making it hard to attract providers and impossible for patients who have nowhere to be discharged. Keeping staff is a function of addressing the cost of living, inflation, and ability to find affordable housing, and these have all been difficult. These and similar comments, together with data on the reasons patients can't get out of the ED or hospital when care there is no longer needed, put affordable housing and other non-hospital facilities where patients can receive appropriate care as the top item on the list of things needed to improve sustainability, reduce inequity, and lower costs. As an aside, each unneeded day a patient spends in the hospital costs the hospital at least $900. The hospital is not paid for this. On July 5th, the cost of a room at the Boston Ritz-Carlton was $659. This is not to suggest that hospitals charge less, but rather to point out that there are much less expensive ways to provide shelter for people other than on the inpatient floors of a hospital. Another comment, getting patients home has been a challenge because the hospitals sending the patients back are also experiencing challenges arranging transportation. This is one of many comments emphasizing the need for new and less expensive transport between hospitals and transport for patients. Another comment, I can no longer afford the procedures or medications. My only option is not to take my medications. People with insurance cannot afford the deductibles and copays needed. So affordability limits access, even if they can get an appointment to see a doctor. Other comments, gender affirming and reproductive health access is an issue, and there needs to be greater availability. Another, no one tells patients about financial services or campaigns available to support their broader health and social needs. Both of these comments reflect inadequate communications and health inequities that need to be addressed. Next slide. Now we will show you the data we used, the efforts we made to conduct a patient-focused and community-inclusive process, and the analyses performed to inform our conversations and recommendations. Our colleagues at Mathematica used U.S. Bureau of the Census data to project changes in Vermont's population from 2020 to 2040. They also gave us data on the number and locations of dual eligibles. These are individuals with sufficient medical, physical, and/or mental health needs to require payments from both Medicare and Medicaid for their support. They are a group needing maximal support to obtain the medical and social services to support their health needs and to reduce the use of emergency departments and inpatient hospital beds. We also obtained data from a January 2023 survey of unhoused people in Vermont. This is clearly an undercount, but points out the need for affordable housing. We used the population projections to calculate current and future needs for primary caregivers and for other preventive health services. We also used these projections to estimate the numbers of cancers, strokes, and hospitalizations for heart disease in the elderly. Together with data from the Vermont Department of Health's Vital Records section, we projected the number of births among women living in each county and also the number of births at each hospital offering obstetric services through 2030. Mathematica also counted the number of 13 individual surgical procedures performed at each hospital over the 2-year period 2022 to 2023. These are all operations for which good data exists, establishing a relationship between the number of operations done at a hospital and the patient's outcome. The total number of each procedure performed in both inpatient and outpatient areas of the hospital were taken from the hospital admissions data set and from the bills submitted for payment. These were verified with the hospital and adjusted based on the numbers the hospital reported to us. My team also did several financial analyses for each hospital to examine the impacts of creating capacity and enabling patients to return to the hospital for services they were going elsewhere to obtain. We will review these in a few minutes. Overall projections of financial stability were done in 3 ways. First, by using the previous 5 years' performance to do a straight line projection of operating and total margins for each hospital through 2028. Clearly, the COVID pandemic and resulting federal dollars to support hospitals were associated with marked changes in the patient use of health care, make that method unreliable. We will show you the results of the other estimates shortly. Next slide. We have taken a very transparent and iterative process to obtain, capture, refine, and update the data used for formulating and evaluating options. We met with many groups and many people. We verified the information for each hospital by asking hospital leaders to confirm the numbers of licensed beds, current staffed beds, and their use for obstetrics, ICU, medical, surgical, or other purposes. We also asked them to confirm the number of operating rooms, procedure rooms, and so forth. If the numbers we had gotten from other sources differed from theirs, we used theirs. We also shared the number of low-volume procedures counted from state billing data and others, and updated these if the hospital could provide a more current value. Mr. Mike Del Trecco and his staff at the Vermont Association of Hospitals and Health Systems performed a survey to collect 2022 data on the numbers of boarders and the extra days they spent in the hospital or the emergency department. His staff also helped with the calculation of, quote, potentially avoidable emergency room visits for each hospital. Finally, we presented to each hospital and their board their community's comments on the experience of medical care, the results of our population projections, estimates of services needed in their service area in the future, the numbers of primary care people required in the future, the numbers of low-volume surgeries, and so forth. We also presented our financial projections for each hospital and discussed the assumptions involved and their future implications. We presented a set of options for each hospital. Some were draconian and others less so. We discussed these options with each board and hospital leadership team. We amended those options based on feedback from the board, eliminating some and adding others. Next slide. The data used for some of our projections and estimations were quite old and thus do not reflect the current state of affairs. Nonetheless, decisions must be made and acted upon based on what is available. The comments we heard and many of the recommendations we are making are the same ones reported by prior state commissions, reports from state agencies, and other consultants over the 5+ past years. The definitions of hospital service areas, HSAs, were based on the current definitions used by the Vermont Department of Health for its data and analyses. Generally, these closely follow county lines. Some hospitals felt their service areas were smaller. Hospitals on the edges of the state felt and had evidence that their service areas were larger, including areas in New Hampshire, Massachusetts, and New York. To account for this, we held the numbers of obstetric patients coming from out of state constant, as we had no evidence on which to base a change in out of state patients. As for other kinds of patients, our analyses considered only the patients living in the Vermont service area and who might return to that hospital for service. In every case, these numbers exceeded the current capacity of the hospital. Therefore, estimation of patient numbers from out of state would not have improved projections for their financial future. Data available from censuses of physicians date from 2020 and for advanced practice nurses from 2019. These do not reflect the number who burned out during COVID and chose a different career path, or those who have retired, or those who have left the state. We dealt with these issues by projecting only the total future needs for primary care people based on visit volumes. Census data on the numbers and types of chronic care facilities dated from 2020 and certainly do not reflect the current state. Many nursing homes have closed. We did estimate potential future needs for each HSA. Data on mental health professionals represent the total number in a county as measured by a recent survey, and thus counties like Windsor and Chittenden appear to have more professionals available than are currently in the community. Many of the mental health professionals are serving inpatients at Brattleboro Retreat or UVM. We did not attempt to estimate the number of community-based mental health professionals needed. National averages are meaningless as the country as a whole is short of these individuals. Please note that we used the year-end financial reports provided to the Green Mountain Care Board by the hospitals for 2023 as the basis for the hospital financial projections through 2028. We had requests to include and to alter some projections based on budgeted performance for 2024, but rejected those as budgets represent predictions and aspirations, not performance. We also took into account the payment mechanisms for critical access, rural, and sole community hospitals. Next slide. So, what is the problem we are solving for? Next slide. Shown here are data from the board. In fiscal year 2023, 9 of the 14 hospitals in Vermont had negative operating margins. An operating margin is like the balance in your checkbook. It reflects the income from patient services minus the expense of providing those services. If you include the 2 additional Vermont hospitals in the red in fiscal 2022, 11 of the 14 hospitals in the state have recently had negative operating margins. This makes borrowing money expensive and difficult for the hospital, and the financial stability of the hospital problematic. I must note that all hospital directors are taking measures to address this. Next slide. This graph shows the past performance of all 14 hospitals over the 5-year period 2018 through 2022 on the left of the gray bar. Note the upsurge in 2021 from an increase in the federal dollars used to support hospitals during COVID. Their continuing performance in 2023 was supported at least in part by an approval by the board of an average 10% increase in hospital charges to commercial payers. That relatively high starting point of 2023, shown in the gray column, was used as the base year for our projections. Thus, we think the projections shown are the most favorable ones likely. While they do not reflect the measures all hospitals are taking to constrain costs, The cost growth shown is based on statements by several hospitals that they expect to limit their growth in expenses to 5%. We think this will be low, as national numbers are often in the 7 to 8% range, and other pressures will probably increase these rates of expense further. The 3.5% on revenue 3.5% cap on revenue represents the Green Mountain Care Board's current goal of constraining cost growth to the level of the Consumer Price Index plus 1%. As shown, all hospitals but one have steadily declining negative margins through 2028. They reach levels ranging from a negative 1.4% to a negative 14.4%. These numbers are considerably worse if a cap of 3.5% on revenue is used, with a projected annual expense rise of 7 to 8%. A positive operating margin of at least 3% per year is needed to maintain facilities and replace capital equipment. A margin of over 5% is needed to build new facilities. We will shortly discuss recent developments making the 7% rise in expense more likely. We did these projections using only current payment methods through 2028 for two reasons. First, because a change in payment methods will occur by then, and second, because projecting any further out requires a belief that all other factors affecting hospitals will not change. Next slide. Hospitals face both operational challenges and financial challenges to maintaining their financial health. Operational challenges include a shortage of all professional staff, compounded by difficulty in hiring them because of housing shortages. Hospitals often have old infrastructure which is expensive to repair, and beds occupied by people awaiting transfer to another care facility or to a home they do not have. Volumes of some surgical procedures are below those needed to maintain excellent outcomes and are an issue. On the financial side, labor shortages are fueling a rise in wages. Salaries and benefits represent roughly 60% of a hospital's total costs. Costs of supplies and drugs are also rising steadily. Hospitals are having to draw down reserves to cover operating expenses. This reduces their ability to afford new equipment or maintain their buildings. Insurance companies are also making it more difficult to get paid by requiring pre-authorization for tests, pre-certification for procedures, or in some cases, refusing payment altogether. Next slide. There are three ways in which hospitals seek to improve their operating margins. The first is to raise prices. We have discussed that. The second is to grow profitable volumes, usually surgical procedures. The third is to eliminate unprofitable services. Shown here are the analyses we use to estimate the impacts on hospital financials of reducing potentially avoidable emergency room visits and potentially avoidable hospitalizations. Both of these reduce revenue, but for small hospitals do not by themselves reduce expenses. In larger hospitals, expense reductions are possible. These are variable expenses. Cutting the number of boarders and boarding days represents a potential reduction in expense for all, but also increased capacity and the ability to generate new revenue by admitting other patients needing and able to pay for their services. We looked at the numbers of people leaving each county serviced by a hospital to go elsewhere to get medical care that the local hospital could give. This was done for both inpatients and outpatients. These patients represent business that could bring additional revenue back to the hospital. We then use the numbers of currently staffed inpatient beds, the numbers of currently used operating rooms, and the capabilities of the current medical staff, and some to be hired in the near term at each hospital to estimate the total number of patients who might be able to come back. In almost all hospitals, that number exceeded the capacity of the hospital to absorb them with currently staffed beds. We then used that number of returning patients who could be absorbed and the procedures to calculate potential impacts on of the business on hospital finances. Next slide. This shows the impact of the volume changes we just discussed to one hospital in millions of dollars. In the graph on the left, the hospital starts with $263 million of total patient revenue in 2022. Avoiding 1/2 of potentially avoidable ED visits reduces revenue by $4.4 million, and reductions in, quote, potentially avoidable inpatient admissions and readmissions cuts another $3.2 million. Reducing the number of boarders and boarding days does not affect revenue because these patients are not paid for. Recapturing patients to the capacity and capability for both inpatient admissions and outpatient surgeries results in a total gain of $10.9 million for a net increase in operating revenue of about $3.3 million. In the right graph are shown the impacts on operating expenses. The hospital starts with total expenses of $280.2 million in 2022. Reductions in ED volumes for this hospital produce no decrease in expense because the area must be staffed 24 hours a day, 365 days a year. This is not true for very large hospitals who may be able to reduce expenses. Reductions in ED boarding days produces a savings of $4.3 million from avoiding the basic costs of housing, and the increased volume of outpatient surgery results also in an increase in expenses of another totaling $4.8 million. The net change is an increase in cost of roughly $0.5 million to a total of $280.7 million. Note that expense still exceeds revenue by $14.3 million. Next slide. This slide summarizes the hospital's fiscal position in 2022 and in 2028, assuming a 3.5% annual increase in revenue and a 5% increase in expenses. In 2022, as we just showed, the hospital is losing $14.3 million from operations, despite all of the changes made. And in 2028, these losses have increased to $40.2 million, although that is an improvement over the previously projected $44 million loss. And that $44 million loss is without reducing potentially avoidable visits and admissions. Next slide. None of these projections take into account these recent policy changes announced in the past few weeks. One is a payment cut to home health agencies, which will further reduce their staffing and likely result in an increase of boarders in both EDs and inpatient units. Another is a 3.4% reduction in physician payments next year, affecting the revenue for hospital-employed doctors. Still another is the requirement for increased RN numbers in nursing homes. While this is a change needed to improve the quality of care, there will be a large impact on hospital staffing. A major impact will be on the ability to recruit and retain nurses and the potential higher wages needed to do this. Another is likely to be closures of more nursing homes, with resulting increases in people using hospital beds, awaiting placement in those facilities still open. This will also increase the need for more home-based care. The most recent policy change is the imposition of a tariff on medical supplies made in China, increasing from 0 currently to 7.5% in 2025 and to 25% in 2026. In addition, one of the presidential candidates has proposed tariffs on all goods made outside the U.S. This would raise the prices on medical devices made in Europe and elsewhere, and on the many medical products and drugs produced in India and the Far East. Such a policy would dramatically increase the costs of medical care in Vermont and elsewhere. Additionally, MedPAC, the committee advising Medicare on its payment programs, has been pushing for several years to reduce hospital payments for their ambulatory services to the level of freestanding community facilities. These revenues currently account for about 52% of total patient revenue in most hospitals across the U.S. Such a change would have devastating and immediate effects. Next slide. What happens when hospitals are forced to close because of financial unsustainability? First, current facilities and many staff could be repurposed and used to meet some of the current and future needs of Vermonters, for mental health beds, for skilled nursing facilities, for rehabilitation units, for memory care units, and other services needed for an aging population. Some hospitals could become centers for new service line, musculoskeletal disease, cardiovascular disease, neurology, acute general surgery, and others. Next slide. The unsustainable trends in patient needs, financials taken together with the unforeseen changes in policy and regulation demand dramatic changes in the sites where care is given and the ways it is delivered. In broad strokes, the changes needed fall into the areas shown. These changes will not occur overnight, and so must be planned for and tested. The support of primary care providers and practices must be increased by augmenting staff and replacing repetitive work with electronic support, and by involving patients in their care. Getting appropriate housing for Vermonters and rapidly implementing home-based care to replace more expensive inpatient care for many common illnesses is needed. Facilitation of current hospital efforts to constrain costs and making additional options available to them is required. The development of new practices, devices, technology, and drugs allows movement of much, if not most, hospital care to the outpatient area and often to the home. 50 years ago, an artificial heart valve implant required major open heart surgery, 2 weeks in a hospital, and 2 to 3 months of rehabilitation to recover. Last year, I had an 89-year-old friend undergo a transcatheter aortic valve replacement, a TAVR. He was home the next day and playing golf 2 weeks later. The standard treatment for appendicitis used to be surgery, and it was expected that if half the organs removed were not normal, the surgeon was underdiagnosing the illness. Today, patients can be evaluated with a handheld ultrasonic device and can be treated with antibiotics, often requiring no surgery. If an intervention is needed, the patient can often be released within 24 hours by using a minimally invasive approach. Vermont has long been on a path to provide maximal care in the community and to move to population health and population-based payments. It must be recognized that the end game of this effort is to reduce the need for hospitals to the point where they largely become intensive care units and centers for complex surgery. We will now turn attention to other ways. Next slide. We will now turn attention to other ways to control costs in hospitals. Many of these are in current use in other places in the U.S., not all. At the top is the sharing of resources directed at information technology and the electronic medical record. The 14 hospitals in Vermont use several different EMRs. 5 are or will soon use Epic. 4 are on a Cerner system. Those on Epic are affiliated with either UVM or Dartmouth. We previously discussed the importance of Vital in linking different hospital systems together and with the multiple other systems used in private practices and federally qualified health centers, FQHCs. There may be other options to do this. For example, Epic does support linking various electronic health records together through a program called the Quote Community Connect program. This might be hosted by one of the academic medical centers serving Vermont and deserves exploration. With or without a tightly linked EMR, broadband capability can be used for a pharmacist in one facility to support a pharmacy technician or nurse dispensing medications in another. It can also be used by a specialist to make rounds on a patient in a distant hospital, as is done elsewhere. Group purchasing of supplies and equipment is in place, and many of the smaller hospitals are banding together to explore using a different group purchasing organization to further reduce costs. They have also discussed creating a central laundry and the group purchasing of employee benefits such as health insurance and retirement plans. Group purchasing of standard diagnostic equipment and maintenance plans will further reduce these costs. Developing a central kitchen serving all the health facilities in Vermont may be another way both to reduce food waste and cost, provide nutritious meals, and conserve space in hospitals for other uses. One could envision such a facility serving the mental health institutions, nursing homes, and other facilities as well. These meals could be prepared in Vermont, flash frozen, transported to the point of use, and heated there for serving. The airline industry and the armed forces do this now. Companies currently deliver these meals at reasonable cost to your home via FedEx to heat in your microwave. A common sterile processing facility is another possibility. Every hospital and ambulatory surgery unit needs an area to clean, repackage, and sterilize surgical instruments so they can be safely reused. These operations require skilled people and specialized, expensive equipment. Some of the devices used require noxious gases and specialized facilities. 2 Vermont hospitals have agreed that one will do central sterile processing for both. A central sterile processing facility could be developed for statewide use and located next to a central laundry, kitchen, or distribution center. I suspect that as the need for inpatient beds is reduced, such facilities will be needed to support the many outpatient areas replacing them. Hospitals and communities could also agree to move surgery and diagnostic procedures out of the hospital's older, smaller operating rooms and into modernized, regionalized ambulatory surgery units that can accommodate the latest technology. These units could specialize in treating specific organ systems or diseases. Such places would improve the care available by allowing the latest equipment to be used and to have sufficient patient volumes to support the numbers of patients and team members needed. They could be placed so they are accessible to larger numbers of people and eliminate the need to travel to a large AMC for academic medical center for services. It would also reduce the expense of renovating and maintaining older, inefficient buildings while preserving jobs for people in Vermont. A centralized lab facility is another possible way to relieve staffing pressures on hospitals, obtain true economies of scale, and reduce the total cost of care. An organization I led couriered all lab work to a large central unit, including microbiology, from smaller hospitals and 70 clinic locations located up to 125 miles away. This was done several times a day. Results were posted in the electronic health record and were generally available within 6 hours of being collected, often less. The capability of doing simple tests needed to manage patients in the emergency room, ICU, or in a busy clinic remained locally. With the recent advent of FDA-certified rapid diagnostic testing for things like COVID, influenza, and others, more testing could be done at the point of care. For people who lack a car or other transportation, taking care to them could solve the problems of both access and equity. Several hospitals could combine resources to equip and staff mobile vans to take care to rural communities. Again, in my previous organization, this was done. Examples exist, one in Vermont of mobile dental treatment, and in other places, mammography units, primary care clinics, mobile screening for osteoporosis, and others. Taking care to migrant farm workers where they work eliminates the need to make them choose between getting care or losing wages. There are many ways hospitals across the state are currently using to share the costs of staffing and of supporting their facilities. These include sharing executives between hospitals, sharing physicians between hospitals, and so forth. There may be more effective ways to expand these concepts. Indiana, for example, announced last week the formation of a statewide nursing, quote, float pool. Could a consortium of hospitals form a corporation to jointly hire nurses, doctors, IT technicians, finance people, and others so that they could move among the hospitals without having to lose their benefits or become part-time employees in separate organizations? Could such a consortium employ a large group of doctors across many specialties to provide not only services in many communities, but also to provide night coverage to emergency rooms and urgent care centers via telehealth? Next slide. The formation and development of the patient-centered medical home has been a centerpiece of Vermont's efforts to provide access to high-quality health care. When such practices are supported by a team of professionals and a finely tuned integrated electronic health record, they are capable of seeing patients in need on short notice, providing care otherwise found in the emergency room, such as intravenous antibiotics and inhalation therapy for asthma, and managing patients with complex medical conditions to make ED visits and hospitalizations unnecessary. The promise of these medical homes seems to be going unfulfilled at the moment. I have come across only 2 that can see current patients within a few days and that have appointments for new patients within a few weeks. Staffing each medical home with an adequate number of trained professionals, each working to the maximal extent permitted by licensure and regulation, is an absolute requirement for success. Shortages of nurses, advanced practice nurses, physician assistants, certified nursing assistants, and receptionists have forced physicians to perform many of the less complicated tasks, such as taking blood pressures and putting patients in the exam room, rather than being able to work with each patient to diagnose and plan a course of treatment. The computerized medical record should move work away from the doctor or nurse practitioner to other team members rather than to them. Professionals in mental health, pharmacy, social work, and other disciplines are important members of these teams. Especially useful are nurse case managers, each caring for a small number of patients with complex medical conditions to improve their health and reduce the need for ED or inpatient care. There are shortages of all these professionals. And in some cases, excuse me a minute. And in some cases, the are needed capacity for x-rays and mammograms. Pharmacists and doctors of pharmacy could be added in larger clinics. UVM is doing this. Telehealth consultative capacity could also be provided more regularly to primary care sites to improve the ability of primary care physicians and others to manage patients and to reduce the need for patients to travel. Staff could be hired for minorities that have special language skills and knowledge of social needs. Next slide. Capacity for home-based care must be developed. These require access to broadband internet, a stable electrical supply in the house, clean water, and available sewage. There should also be central monitoring facilities or capability. There needs to be adequate support in the home from family or others or home health services. A clinician visit is required at least daily. Medicare requires 2 visits per day. There must be the availability rapidly of transportation to and from care, especially if some complication occurs. And there needs to be adequate and appropriate payment for these services. There are a number of options already underway. Primary care diagnostic options, as noted with specialists and others, can be and are being accomplished in many places using telehealth. Home-based kidney dialysis and support if a patient needs a chronic ventilator have been done since the late 1970s. Support for home-based cancer care and other services are being provided around the country. For example, the Huntsman Cancer Center in Salt Lake City is noted for its home-based program of providing cancer care. There are also numerous programs around the country providing hospital care at home. An example in Boston is the Massachusetts General Hospital, but there are multiple others in other cities and towns. Last, a recent program to provide emergency department care at home for relatively simple things has been put in place by Atrius Health in Boston. Next slide. This slide shows the variety of options available for facilities, machines, and additional health professionals that could supplement current healthcare capabilities in Vermont and meet the needs expressed in our community and provider meetings. First, regionally placed freestanding diagnostic facilities or repurposed hospitals and ambulatory surgery centers could be developed and sited so that access for the greatest number of people in that area is possible. We have discussed these units previously. Both of these facilities could be placed together and near a large primary care practice. Unused commercial buildings, such as a supermarket or vacant retail space, could be repurposed. Kiosks for patients to use for telehealth appointments with distance specialists could be placed in public areas such as libraries or grocery stores or in primary care offices for consultation by specialists. These could contain the electronic stethoscope, electronic ophthalmoscope, and electronic otoscope that are available and that the patient could use under the direction of the clinician to make physical examinations possible. These have been used elsewhere and were placed in Chicago in the lobbies of office buildings and one of the train stations, although I believe they closed during the COVID pandemic when people did not visit downtowns. We have mentioned the use of mobile vans for care and screening. Patients and ER doctors report difficulties with obtaining medicines commonly prescribed in the emergency department for infections, blood pressure control, and other common illnesses. Pharmacies are often not open at night and in some areas not available without traveling some distance. A dispensing machine, similar to the Pyxis drug dispensing machine used by nurses, could be placed in the ICU to make such common meds available immediately to patients. Indonesia is considering this currently as a way to make medicines available to people on its thousands of islands. Community pharmacies and pharmacists are giving vaccines currently, but are not paid for the administration of the shot. They should be paid for this. Pharmacists could also be allowed to refill chronic medications that are not controlled substances. They could also diagnose common infections using FDA-approved rapid testing. These services can be done by ordinary people in their homes, and treat these using a physician-approved protocol. When I spoke to the Vermont Medical Society about this last week, they did not support the idea because they felt it would further silo care and that their practices were the only ones that knew all the medicines a patient was taking. Their alternative was to continue to invest in patient-centered medical homes, which I agree with, but I will also point out that significant increases in the staff of patient-centered medical homes and other physician-based care sites may be some time off. So alternative types of providers are needed for the short and intermediate term. Furthermore, the 2023 report of the Blueprint for Health stated that only 65% of Vermont residents in 2021 received care at a patient-centered medical home. I would also note that unless the patient-centered medical home receives information back from the pharmacy about what prescriptions were filled, the doctor does not in fact know what the patient is actually taking. A national study showed that 20 to 30% of prescriptions written are never filled. The pharmacist knows what the patient is actually picking up. EMTs and paramedics are providing vital home visits in a few Vermont communities and in many others around the country. These individuals should be full-time, paid well, and supported by a PMP, a per member per month payment for services. Nurse case managers are urgently needed and must be embedded in each primary care practice. More community health workers are needed. Employing those with needed language skills and having sensitivity to the several cultural issues is important. Allowing immigrants with professional training to practice their professions in the state without repeating residency in the U.S. would assist in getting additional professionals into the state. Apparently, the Federation of State Medical Boards is currently considering this issue, and we may hope for some guidelines to get this process started. Certainly, such people could be used as interpreters and scribes in practices.
I've lost Bruce.
Yeah, I think he got disconnected. I'm gonna call him, make sure he sees that.
Great, thank you.
Mm-hmm. He's coming. He's on his way. Just here he is. You're still muted though, Bruce. There you go. Okay.
Yep. My apologies, Mr. Chairman. I had a computer difficulty.
I thought it was me.
No, it's me.
Thank you.
Thank you. Sorry. As Vermont continues down the path to population-based payments, the following principles need to be kept in mind. They also help to preserve health access and jobs in the community, as well as to improve equity and quality while constraining costs. First, there must be tight alignment of financial incentives among all participants. These incentives must reward access and appropriate use of resources, as well as attaining current metrics for quality. Second, there must be timely sharing of accurate clinical information and on financial or utilization performance with all participants. Without this, they cannot self-correct in real time to achieve the desired outcomes. Next, there must be adequate resources available for primary care, mental health treatment, and other preventive services in the community. These must also share the same goals and financing. Specialist and diagnostic services must be available to patients when needed, and access to appropriate levels of care other than acute inpatient beds must also be available. Pardon me. Tertiary and other referral facilities must be able to accept and treat patients in a timely manner. And last, transportation for patients to and from medical care and for appropriate timely transfers between facilities must be available. As I noted in my previous testimony, none of these conditions is currently met in Vermont. Also at the bottom, again, the end game for population health is a movement of patient care out of the hospital and a shift of hospitals to more intensive care. Next slide. Continued maintenance of the status quo is untenable. In my opinion, the inexorable population changes leading to a larger group of aged people and a declining number of working age people, when complicated by national shortages of professionals and increasing pressures on cost, make the status quo maintenance unlikely. If hospitals continue to use the same operational levers to try to improve their financial condition, many will fail. Continuing to increase prices is neither affordable nor acceptable to Vermonters, as noted in our community meetings. With a declining number of working people, ever higher premiums in commercial insurance will be needed and will produce fewer dollars. As people age into Medicare, many are and more will choose Medicare Advantage plans, and so will move from the fee-for-service Medicare to commercial plans. This will ultimately erase any current benefit for critical access hospitals that they get from being paid 101% of their Medicare costs. As our financial analyses show, variable expenses for small hospitals are tiny, and increasing volumes of the services they are currently able to offer does not significantly improve their future. Current efforts to support access to health treatment in many communities have not been successful, as evidenced by comments from both Vermonters and providers. There are many activities devoted to prevention and some early efforts at community-based treatment for acute mental illness. Some nursing case managers are available in patient-centered medical homes to manage complex patients, but these seem to be few in number. Dramatic and innovative new approaches to delivering health care are required, and the time to design and begin to implement these is now. Given the rates of financial deterioration in hospital performance through 2028, the next 4 to 5 years must be spent designing the needed changes, prioritizing them, and getting them done. Information technology, new medical devices, and artificial intelligence will all play a role, but the issues outlined on the previous slide must be addressed as planning for additional changes is being done. The government and citizens of Vermont currently spend well over $3 billion on health care, and additional monies are spent on social service and other programs through the Agency of Human Services. The dollars are there, but will need to be spent in new and different ways and on different kinds of care. Identifying individuals with the most complex needs, the dual eligibles and others, and prioritizing their care would offer reductions in cost in the near term and free up dollars to permit investment in other areas. Next slide. Our next steps are to conduct 14 in-person community meetings this month, followed by a statewide virtual community meeting on August 5th. We will use these to write a final set of options for each health service area and many other groups for the Green Mountain Care Board and the Agency of Human Services to consider and use in the transformation process that the Agency of Human Services is starting shortly. This report will be complete in mid-August and can then be delivered at the pleasure of this board. Next slide. Thank you for your attention, and I welcome questions or comments, Mr. Chairman.
Thank you very much. I have one or two that I'll put you on the spot. And if you're unable to answer sitting here cold, that's fine. But I wanted to go to slide 15, if you could.
Yep. Irene, can we go to, there we go. Yes, sir.
And so this is the current financial shortfall on operating income for an actual Vermont hospital. This is an illustrative example of real hospital financial data, correct?
Yes, sir. On the left.
Yeah. And then on the right is that exact same hospital's projections through 2028 based on whether or not the state targets for revenue growth are met at 3.5%, right?
Yes, sir. And including the changes bringing patients back from leaving. Yes, sir.
Okay. And if we're unable to bring back the patients, then these negatives would be deeper.
Yes, sir. As shown in that slide with the multiple lines.
Right. Okay. So if we wanted this particular hospital to be financially solvent, the state would somehow need to come up with these dollar figures. Is that right?
Yes, sir. Roughly in 2028, 40.2 million, but certainly pretty large numbers between now and then.
And do you have these calculations for, hopefully, this is a rare circumstance, but I presume it's probably not. Do you have the calculations? Do you have the amount of money in total for 14 hospitals we would need to find to support them at current operating levels?
I don't, but it would certainly be north of 250 million and probably north of 300 million, but we can certainly get that number for you.
Okay. Yeah, so what I'm trying to understand is if we were to maintain the status quo in terms of our structure, how much money each year would we need to find?
Well, somewhere, but let's say at a minimum, $250 million.
Every year?
Yes, sir.
Okay, that's the only question I had. Thank you for your presentation and all of your work and effort and travel here to Vermont. And I'm looking forward to seeing your presentations this week. I'll open up to the other board members for questions they may have.
Thanks, Bruce. This is Dave Merman. Also, gratitude for all the work and the presentation, and I'm looking forward to some of the community meetings upcoming. One question I had for you with regard to the individual hospital financial data or statewide is it right that you don't include non-operating income in these charts? And could you explain rationale and thoughts on that?
Yes, sir. Certainly non-operating income is being used to support some of these losses. However, that depends on the performance of the stock market. And I'm unable to predict what that'll be. So we focused on operating in this a bit, but I would note that those figures and that support are reflected in the previous performance of the hospitals, which still required relatively large increases in the allowed rates. So these, while they may not be the worst figures, certainly would represent, well, let's say the base year 2023 does include, no, this is all operating revenue. So yes, it might make it a little better, but it would still require a substantial amounts of support.
Yeah, I mean, because I was recently talking with a friend who was administrator at a hospital in a different state, and he said that they effectively their hospital is a bank that runs on operating, runs on investment income to offset losses and providing care for they have a fairly public mission at their hospital, losses and providing care for their region, and I was just curious to sort of think about that, and then also that I would assume then creates a lot of disparities among certain hospitals that have large amounts of investments with others that have that are kind of running on a slimmer amount of days cash on hand and investable money.
No, your friend's right. I mean, certainly the larger hospitals and health systems are essentially investment people and banks. I would note that the trend in Vermont over the last number of years has been for hospitals to draw down those reserves. And because of fairly tight limits on the allowable rate increases, they've had to draw down some of those bank accounts and also have not been able to tank them up. So with the exception of a couple of the hospitals, my deep suspicion is that this would not substantially change. I think we certainly could run them, and we will for the final report to see what the impact is. But I note that graphic provided by the Green Mountain Care Board with the previous and current negative numbers for hospitals would make even that inclusion probably unhelpful.
Thank you.
I guess I can jump in here. So first of all, huge thank you, Bruce, and to your entire team that I've had some pleasure of working with over the past few months. Your outreach across the state and over the past year is literally unprecedented. I mean, the meetings that you've had and the opportunities to speak to patients and providers and agencies is crucial to the success of this project. The demographics and the financial projections, as I said, I think in previous meetings are sobering. Your recommendations and these options offer us some hope, some possible paths forward. So I really appreciate that. I think I said this before, and I'll say it again. I think this is some of the most important work that the Green Mountain Care Board in collaboration with AHS and with the support of the legislature has ever undertaken. I think we can finally start to deal with the underlying problems versus, I think, treating the symptoms, which I think is what we've been doing for years in some cases. So I'm really grateful to you and your team for jumpstarting some much needed conversations. I wanted to ask you a little bit about, if you could speak a little bit more about your recommendations around a regional ambulatory surgery center and regional physicians group. Specifically wondering if you could just speak a little bit more about how that might affect recruitment. We know there's a national shortage of physicians, and I've heard you talk a bit about call schedules and the challenges around recruiting specialists. And I wondered if you could speak a little bit about that. And also some of, you have touched on and done some analysis on low volumes and the relationship between volume and quality. So how would this recommendation and this option support ensuring that all Vermonters have access to the highest quality care with providers that are doing volumes that support that quality? And I guess sorry, this is a long-winded question, but balancing that need to ensure quality and having enough volume with the need to ensure access, right? So in a rural state, you've got you want to have enough volume to ensure quality, but we're a rural state. So I'm just wondering if you could speak a little bit more around some of those recommendations with those thoughts.
Yes, thank you very much. All very good questions. And I think we addressed all those when we discussed in much more detail the options with each of the hospital folks. But to respond directly, the recruitment of physicians has changed a lot in the last number of years. I can say with some authority, 50 years ago, the call schedule was 1 and 2, one every other night. And in fact, many people in private practice worked every night, except for the 2 weeks when they took vacation and had to hire somebody to cover. 20 years ago, it became 1 night in 3. In more recent times, it is currently a call schedule of 1 night in 4 or 1 night in 5. This requires that you have 4 or 5 physicians in the same specialty. So 5 cardiologists or 5 neurologists or whatever in order to have that call schedule. And in fact, this point has been raised by a number of the hospitals as they try to hire specialists. The only way, and as you comment, Vermont is regional. The number of people in each hospital service area, except for Burlington and Chittenden County, is generally in the 25 to 30,000 person range. That is not enough to support 5 cardiologists. And in fact, what we see in the state is if one hospital can recruit a single person, they often share that with another hospital, both to provide support to that other institution, but also to divide the costs and provide enough patients for that person to see. So if you want to be able to recruit and maintain a group of 5, for example, you need a larger population. The way you get that are one of the 2 mechanisms that we are suggesting. And in fact, the formation of a regional medical group is a suggestion that one of the hospital folk made to me. So it is being thought about within the state, at least by some. This would certainly require kind of a group, the hospitals to participate in some sort of an organization that could do that and provide stability. It would need to be supported, I think, by regionalization of certain specialty care, much of which can be provided on an ambulatory basis. In fact, for example, the vast majority of total hip and total knee replacements being done by hospitals and their staffs in Vermont are being done as an outpatient process. And many people have experienced this, as I may have noted several weeks ago. I recently had a knee replacement at a substantial hospital in Boston. That was entirely outpatient. I went into the OR at 6. I was out by 1, recovered, demonstrated I could walk with a walker, and I was home by 6 o'clock. So 12 hours in and out, almost door to door. A number of other things are done same way. Gallbladder treatments now are largely outpatient. So, but again, it will require some regionalization. Another way that these larger groups of physicians could be supported is to substitute the telehealth support by specialists from Dartmouth and from other places around the country with the telehealth support by these on-call physicians. And in fact, they can do call from home. And in a prior life, we had radiologists reading MRIs and CTs from a desk in their house at night to support the emergency room. So these things are all done. And that would require, in my view at least, regionalization. You could do it with the current facility, although, as I noted, most of those facilities have pretty small operating rooms, and some of the equipment needed to do minimally invasive surgery and some other kinds of surgery require larger operating rooms to accommodate the equipment and the extra staff. And they may require more air conditioning because they generate heat. As to low volumes, as I mentioned, those 13 surgeries are all supported by medical literature. And in fact, we had one hospital that when we got there said, gee, we already decided to stop doing this. We did not encounter any adverse comments from the medical staff about those volumes. I should note, and did not in my comments, that sometimes a patient shows up and they are in such urgent need of surgery that you have to do it. But some of these numbers are 9 or 12 or in that range over 2 years. When you think about that as a patient, if somebody's only supposed to do 12 over 2 years, that's one every 2 to 3 months, which is not good. I did also share with the hospitals that there are comments from the American College of Surgery around this idea of a Center for Acute General Surgery. So if you had transportation, which, like I said, is currently a problem, you could move patients with urgent gallbladder needs or other conditions to a well-staffed Center for Acute General Surgery that would have the appropriate equipment and so forth to take care of that patient. Now, still, once in a while, somebody's going to show up and you're going to have to work on them. But you're going to have surgeons on call to do that, and you're going to have to be able to recruit those folks. So I think there are alternatives. I did not comment on obstetrics. We talked to a number of hospitals about that and about the anticipated changes, declines usually. But for a number, there are a lot of patients leaving their areas to go to a large hospital, UVM, Dartmouth, whatever. And if services were more readily available in the community, many of those women would stay with the local hospital, obviously subject always to patient choice. So you don't know that until you try it. I will comment, a couple of hospitals were quite surprised at the numbers of people leaving their area.
Great. Thank you so much, Bruce. I really appreciate it. I want to make sure there's enough time for other board questions and public comments. So I'll hold any other questions I had, but thank you.
I just wanted to say thank you. It's a lot to digest and a lot of really good information, and appreciate the thoroughness and thoughtfulness that went into the analysis. I don't have any immediate questions, but I'm still digesting.
And I'll join my board colleagues, Bruce, in saying thank you for all this work. I know it's a team effort. Thank you for your team bringing it all together. You mentioned early in your presentation that many, if not all, of these ideas had been proposed previously, not all packaged together, but there have been similar proposals over time. And I'm wondering if you have thoughts or ideas how this community engagement could help spur action when previously the action hasn't happened.
Well, I think there are a couple of things going on. I think number one, many of these reports were perhaps not shared well with the communities. There have been sufficient changes among the staff, both at the Agency of Human Services and in the legislature during the past few years, that others may well not be available, recognized or known to people. Some of the more recent ones, for example, addressing workforce, are well known, and I think communication about those has been done. But there are others that really haven't been. Or some of the previous consultant reports, I think, were criticized, and rightly so, because they omitted certain considerations. And as I tried to point out in my comments, we made a real effort to go back to the hospital several times, including a number of times I haven't counted with emails and so forth, to get information from them, which is what we used for these estimates. So I think there were perhaps some other issues involved as well. We've tried to address those.
Yeah, I listened when you said earlier that when there was a discrepancy between your data and a hospital's data, you used the hospitals.
Yes.
And I think that makes these findings all the more compelling. I'm still hopeful that this community engagement piece now will lead to further community engagement and energizing. We have a very involved community in Vermont.
Yes.
They care about healthcare quite a bit. We have a lot of public comments. We have a lot of people routinely coming to our meetings. But it seems like it's going to take a real groundswell of concerted to arrive at a concerted effort to overcome the barriers and the resistance that's happened previously. So I think your report and these presentations are so powerful because they bring so much together in a package that we can all talk about.
Thank you. I have to note, Vermonters have a long history of coming together to solve problems. And in fact, when you look at the community health needs assessments that the hospitals all do every 3 years, and you go down the list of what they've identified, many of these issues have been put there.
Yeah.
And communities are certainly taking action to try to address food and transportation and housing, for example. But they say we need mental health and we need practitioners and so forth. And so our report does not really address, for example, food. But we certainly do address transportation and housing and need for other things. And so, yes, I'm, as you, very hopeful that as we are able to clearly communicate to the communities what some of these needs are, and we're not going to discuss at a community level options for that hospital. Those have been discussed with the board and the medical staff. And having served on a bunch of hospital boards, the decisions around what happens are the fiduciary responsibility of the boards. They can be supported or changed by community input. They can be supported or changed by actions that various state agencies take. And I am very hopeful that those things will happen because of better communication, more involvement. And then one of the hopes for these meetings is that they will help set up and facilitate the actions led by the Agency of Human Services that will start shortly.
Thank you very much.
I'd like to open up to the healthcare advocate for any comments or questions they may have.
Thank you, Mr. Chair. Mike Fisher here. Bruce, first a question. I'm going to admit my question is adjacent to your analysis, so I hope that's fair, but I wondered if you had thoughts about what all of this means, what the implication is, given all of this on non-hospital employed providers.
I think it will be helpful to them. Certainly largely the primary care people are not hospital employed. There are some that do employ primary care physicians, others that affiliate tightly with FQHCs. The specialists generally are employed by the hospitals because otherwise it's difficult to recruit them. And as I noted, the economic conditions are often that the volumes that they see can be low. So I do think that that planning for what I will characterize as the inevitable for some places, that planning and beginning to implement plans will reassure the non-hospital based and hospital based people that, number one, there's a future. Number two, that those things will be done and can be done in a way that provides additional support to them. And so I would not expect, if those things can be accomplished, that there would be adverse outcomes for the non-hospital based folk. I would also comment that a lot of this would relieve pressure on emergency room physicians and a number of hospital employed and hospital based people, because if you plan for something, you can adjust things so that the conditions are improved.
Thanks. I think I'll just make a high-level comment, very much in line with what board members have said previously. Appreciation for all the work on a part of Bruce and his team. Also appreciation for the board and for the Agency of Human Services and the legislators. I know there were a few on here earlier for making this happen. We think it's really super important that we look at this eyes wide open, even though it's hard and it's scary. And, it's scary from a health access, from the perspective of the healthcare advocate about access to care. I got to imagine it's scary and, nerve-wracking if you're trying to run a hospital. And so I just, as we step into this next weeks, I want to recognize that there's, we're going to be traveling to communities where people are going to be, frustrated, scared, maybe want to shoot the messenger. I understand that impulse, and that the HCA is engaged and happy to partner in any way we can to support this process. Thanks.
No. Well, thank you. You were and your team involved in a lot of the community sessions and several of the provider sessions. And, I have not said, but some of those community sessions and the comments, got me to tears. I mean, the experiences people have, and some reported, are alarming. I wonder that, the access to care in particular has not been good for a number of years. And in a sense, it's like the frog that gets put into cold water that starts to boil. It takes time. You don't recognize the change, right? I remember I was stationed in Addis Ababa, Ethiopia during a revolution. I was there 10 months. When we got there, you could go bowling at night. Over time, people put up machine gun emplacements, and there were roadblocks, and they searched your cars. A curfew was put in place. You couldn't go outside. Some poor guy from the Norwegian embassy was shot in the head because he was traveling actually an hour before curfew, but the folks were given guns and not watches. And so you got to the point where you just adapted. And finally, when we were thrown out of the country with 72 hours notice, we got to Athens. And I remember what a dramatic change it was to be able to go out on the street and not worry about getting shot. So it seems to me that some of the changes that have occurred to the Vermonters and the other residents and the physicians and the nurses and the hospital boards have been slow and over time, and therefore have been adapted to or accepted.
Thank you.
All right. Thank you very much. I'll open up to public comment via the raise the hand function. I'll try and call on people in the order in which their hand is raised. Jill Olson, how are you?
Great, thanks. How are you? Thanks for calling on me.
Yeah.
I just had some initial reactions that I think you're likely to hear in the community from home health agencies that I wanted to share. So I'm not going to speak to sort of the broader plan, but I'm going to be pretty focused on home health. One is that actually direct support to home health agencies or to long-term care facilities. So I see support for FQHCs, mental health systems, primary care. I don't see that for home health or for long-term care facilities, despite, I think, your acknowledgement of how critical those parts of the system are. So you mentioned some expansion of home health and expansion of care at home without actually talking about supporting home health agencies at all. I appreciate the reference to our most recent Medicare cut. That is coming for sure. But I actually think Medicare Advantage is the greater threat. And as far as I can tell, that is not in your slides at all. So I heard you reference it a bit, but that's a much bigger threat to home health agencies. And then another omission that I think is interesting, as far as I can tell, this is also not there, is the potential for improving our hospice utilization and length of stay in Vermont. Yes. They're low. It's a huge missed opportunity in Vermont, and it's really can't be up to hospice to expand hospice. It's really more of a physician intervention to expand hospice, and we are really, really missing out on an opportunity to improve care and to reduce costs. So I hope you'll consider adding that in your as you move forward with this.
So thank you for those comments. I was not explicit enough. We do have those in a list. Funding is going to be critical. Additional staff. Absolutely agree with you about hospice, and I apologize for not pointing it out. But I do think as the state considers funding, certainly being able to move some funds around and support activities, because as you noted, home health is essential, really, to what people need. It is, I think, a prerequisite is a house to go to or a home to go to of some sort. But thank you for those. We will certainly include those in our final recommendations.
Thank you. Appreciate it.
Jessa Barnard. Oh, and sorry, just for people who represent industry or particular entities or lobbying groups, please just identify with whom you're associated for people.
Yes, good morning. Thank you. Jessa Barnard. I'm the Executive Director of the Vermont Medical Society. And I just wanted to make a brief comment since Dr. Hammery, I think we were one of the few organizations named in the presentation this morning. So I just want to make sure the board is kind of aware of our full interest in this work. We really appreciated the meeting with Bruce and his team last week. We met for over 90 minutes. And while we did have a concern with one or two of the specific recommendations, our really big picture conversation was around making sure that primary care is supported and strengthened. And we gave a lot of really specific examples. I know the board is well aware from panels you've had on primary care, from your PCAG group. We referenced a white paper that the Medical Society has worked on with the American Academy of Pediatrics Vermont chapter, the family physicians, talking about not only financial support, but making sure we continue things like scholarships, loan repayment, support the new residency program in development. We'll keep working on reducing administrative burden and supporting telehealth. A lot of these things are really are underway, but we just wanted to make sure that the report referenced a lot of existing evidence-based programs that are in place and not just looking at sort of new or alternative ways of providing primary care services outside of the primary care medical home. And I also want to mention, one thing we are really concerned about is how this work dovetails with the AHEAD model, especially with the announcement just of last week that Vermont was accepted. And we know we've talked to this board as well about potential destabilization, particularly of independent primary care practices. So how we really look at the specifics of what the AHEAD model may bring, but may also we may lose as a state and in terms of support for primary care. So we would hope that these streams of work could kind of come together and make sure that recommendations in this report may also identify ways to make sure that we're moving forward in a sort of unified, systematic way and not actually moving away from support for primary care in the state. So thank you. And I'm happy to share, we shared a several page kind of thoughts on the work with Bruce and his team. Happy to share that with the board as well.
Right. No, thank you very much, Jessa. We also learned a great deal from that meeting. I did comment, I think, on the scholarships and a number of the other issues in the testimony a couple of weeks ago. Clearly agree and, tried to discuss some of the things that were needed to enhance primary care practices and to allow physicians more time to see patients. So, but thank you for those comments and also for your advice.
Joe Wooden, Mr. Wooden.
Yes. Hi, can you hear me?
Yes.
Thanks very much, Bruce. I've heard this a number of times. I like some of what you're saying. To be honest with you, I don't like some of what you're saying, but this is all part of the process. And every time I hear it, I learn more, and I really appreciate the thoughtfulness that you put into this. And you sort of marched through what you did, the amount of listening that you did, as well as looking at data is very impressive. I don't know, we have a hard time dealing with outside consultants. I hope we learn to embrace this and not necessarily fight over the small issues. I know a couple of folks that have heard it they're concerned about some of the issues, but directionally, if we think it's correct, let's all embrace that. But we're not going to take lightly to this because, you know, nobody does in terms of change. So we're a small family in Vermont, which is really great. The bad news is, you know, families are some of the sources of the greatest discontent and arguments are in family members as opposed to colleagues or professionals. Your page 18 with all the suggestions is great. Some of those suggestions are unreasonable, they're crazy, they don't make any sense. And yet, the more I think about them, I say, it's so easy to discount and defend and to stiff arm. So maybe we should think about this. Somebody said to me, oh, the idea of food that would be flash frozen and sent to hospitals, how detestable and what a crazy idea. But then I sort of think about what you said. Imagine if that food was all prepared in Vermont and we actually bought it from local farmers and it was organic. I think we'd all probably change our mind and say, isn't that great? We're saving a bunch of money. We have something that is all local and it supports the Vermont way of life. So I'm still learning from these reports. I wanted to make a couple of comments and have a question. It's a lot of money each year to try to keep us sustainable. I think we're going to have to really be less selfish. And I work at Copley. I'm a CEO at Copley. I apologize, Chair Foster, not mentioning that. So I'm one CEO, although I've worked in 4 hospitals in the state of Vermont. So I think it's important we try to check our egos and try to really think about this because the future doesn't look very promising for many of us. A question I have for you is, you know, the thought of how we lead together, maybe not just the hospitals, maybe we do expand the tent to include, which we've talked about for a long time, maybe include primary care because it is so important, maybe include others, and then maybe we can collectively all lead and own this. But how are you going to get, because all the hospitals are private. This is funny, people don't know that. People think the hospitals are maybe like the state hospital or like the school systems. And it's like, no, the hospitals are all private. So that's good news and bad news. The challenge is we really need to get the boards involved, which represent the community, the CEOs, and the medical staff. So how are we going to get the boards, which oversee and manage the CEO and have guidance over the medical staff? How do we get these 3 groups together with AHS and the Green Mountain Care Board to really say this is a serious discussion? Because when we forget that, it creates that animosity. So that's my question about how to get everybody together. Thank you.
Thank you. It's probably the most important question raised today. And I want to, before I answer the question, thank you and all the other hospital leaders with whom I've met. I've learned a great deal. Hope I've taught a little, but certainly learned a great deal. And there is a lot going on. As I commented, you made plain, the hospitals are all independent, self-sustaining, and private. And the board of each hospital is the group that's going to make the decision about what happens. Now, as to your question, I think getting everybody in the same room, as we are trying to do for these community meetings, to get people from the board, the leadership of the hospital, the medical staff of the hospital, the community, some of the business leaders, people from the Green Mountain Care Board, people from the Agency of Human Services, some legislators, to get all those groups into one room to have a presentation about here's where things are, here's where it looks like things are going, unaltered. Right, as I noted in my comments, all your colleagues and your staffs are working real hard so this doesn't happen. And part of my presentation was to say, unfortunately, despite many of those efforts, with the aging of the population, with the trends in payment for a lot of reasons, and with just recent unanticipated changes, and I'm sure more to come, things really need to be addressed and changed. So the realization among all the parties in the room, as you commented, that change is needed and that everybody has to be involved in those conversations. I mean, what change is needed it sort of depends on where you sit and how you're experiencing it. And I hope that's one of the things that came out of this process, is that we listen to all these folks. I've tried to represent as best you can, comments from, I'll say, out of those 1,600 people, probably 500, but a lot of heads nodding in the rooms. And we only could show a half a dozen or 10. But I think, to your point, that engagement from all groups, and I doubt a consensus will be reached. But at the end of the day, there should be agreement. Number one, the direction is correct. Change needs to be made. Number two, people in the room who can make those decisions and fund them or by whatever means necessary. And hopefully a lot of it by rearrangement of current funding. That's going to take some time to implement those. So absolutely accept your point, and what's I'm certain going to happen in the community meetings. I mean, I've been there before. It's always difficult, and I appreciate that. And it does take time to absorb this. I mean, many people are going to hear this for the first time. Fortunately, the slides will be available on the Green Mountain Care Board website. Our final report, when it's given with all the data, will be available on the Green Mountain Care Board website. So Joe, thank you for your comments.
Thanks.
Mass Farrell, I hope I'm pronouncing your first name correctly. Is it Mass?
Yeah, thank you. Yeah, it's pronounced Mads. I'm a Vermont resident, a parent, also a East Asian medicine practitioner student at NISA, which is New England School of Acupuncture in Worcester, Massachusetts, part of MCPHS. And questions kind of that were brought up along this talk. I was wondering how the paradigm of East Asian medicine has a space in the healthcare system in Vermont. It's with thousands of years of clinical efficacy proven, a great option to consider more deeply, to represent so many of those levels of patient outcomes. Totally can be done at home care. We can see the whole person. So across the specialities that are of allopathy, and we know how to communicate also with biomedicine. We're national board certified to do so. So I guess that question's there. Thank you.
No, thank you. My captain in Ethiopia did acupuncture, quite effective. Certainly, probably a very good alternative to chronic opioids and other things. So it needs to be taken into account. I would be hopeful that these community discussions and the process going forward would also take that into account. Thank you.
Kim Fitzgerald?
Yes, thank you,
How are
Chair
you?
Foster. I'm Kim Fitzgerald. I'm the CEO for Cathedral Square and have affordable housing I oversee about 1,300 apartments of affordable housing, as
Good.
well as 2 of those are long-term care communities, memory care and both assisted living, and one specializes in memory care. And then also, as you've heard, Bruce, I know you've met with us, I oversee the SASH administration across the state and out of the state. So I bring a unique perspective, I suspect, to the table, but I wanted to echo Jill's previous comments about long-term care and community services. Excuse me. For an example, our memory care community, we have just low reimbursement rates. It's not sufficient. The state did a rate study, and for the nursing home level of care, ERC patients we're supposed to get about a 55% increase to cover actual expenses. And this state fiscal year 25, we will see a 3% rate increase. So it's not enough, to cover expenses. And right now, trying to work with, we have previously taken people living at the hospital to our memory care community who have lived at the hospital for 6 months and 8 months. And currently we're working to bring in a few more from the hospital currently, because we have a couple openings. And unfortunately, we are unable to do so because they need one-on-one care and we do not have the staffing to support it. Right. So without that reimbursement rate increase, we're not able to hire the staff. We can't compete against the hospital rates of staffing. So it definitely is a circular, obviously, issue, but until we can get those rates increased, then we can't get the people out of living at the hospital, even though we all want that. And they're trying to do that. And second, I just wanted to say expansion of what is working. You mentioned about, like, for example, the pharmacists knowing what people are taking for medications. And I want to say our SASH wellness nurses, who are RNs in the home where people live, know what people are taking, because even if they fill a prescription, they may still not be taking it. So that I just want to make sure that we're expanding on what is working, instead of hospital at home, or I think you said ED at home. Let's continue our SASH, which is support and services at home, and expand on that. And we already know it's working. And we have done and can continue to do telehealth appointments at home, where you have the nurse in the home, with the practice on the other end. And we're also working right now on the Medicare wellness visits, doing those as well through our SASH wellness nurses in the home, and then protecting the primary care practices time as well. And again, using people at the top of their licenses, and not having, using people outside of that, higher ends with a higher cost payment. So just wanted to make sure you would think about those things in your final report too.
Thank you. How many more facilities like yours do you need in the state?
A lot. I have over, I say this a lot, Cathedral Square has been in existence for 47 years, and I have about 1,300 people on my waiting list. So I could build tomorrow what it's taken me 47 years to build, and not barely touch the, meet the need that I'm seeing today. And my long-term care, I could build at least 15 more of my memory care communities to meet the need that we're seeing.
Thank you. You're doing a great job. What are the, other than funding, which is huge, and we'll deal in more detail with funding in the final reports, as some of these issues that the state's thinking about are perhaps clarified. Other than the funding, and staffing, let's say, what are the issues that you're trying to deal with? Are there things that limit your ability to build more facilities?
Those are the top two. I mean, it's definitely staffing is the first one. In fact, we've been, in the last 5 years, we've had 3 communities who have wanted to sell to us, who we've wanted to acquire, but it's because of staffing that we have been unable to do so. And then it's the reimbursement rate that obviously plays into some of the staffing struggles, but obviously it's more than that as well. As an aging state, we just do not have the demographics of the staff of working age to support the aging demographics.
Great, thank you. And
then costs. I would just add building costs. I mean, as far as building affordable housing, building more long-term care communities, it's the costs have just skyrocketed. So that's another thing. Used to take us, maybe eight resources to build a community. Now we're up to 15, 16, 18 resources to build a community.
Okay. Thank you very much. I'll just quickly note that the service that you are providing hospital at home. with all
Yes.
the things you mentioned. So,
Thank
again, another perfect example in Vermont of things that are going on. And if we could find ways to expand them, be great.
Olivia Sweetnam.
Hi there. I'm Olivia Sweetnam. I'm the CEO of Grace Cottage. Thank you, Bruce, for your presentation. Thank you also for being so engaged with us. We really do appreciate your time and the conversations we've had. They've been really valuable for us. I just have a couple comments. First, I think, David, you brought up the total operating margin versus total margin. For us here at Grace Cottage, obviously, we're quite little, but although we do see that -7, 7 point close to 8, we really are whole, generally speaking, year over year because of the massive, really philanthropy efforts and community support we have here. I think that type of support has shown to be stable for us year over year. We obviously don't want to depend on that, though. And as Bruce knows, here at Grace Cottage, we're aggressively growing outpatient rehab, building our imaging services. We're building a new primary care building and exploring outpatient Jerry Psych. So all of those pieces, parts, components. But I just want to double down on, Bruce, your last presentation, and of course you've hit on it here too. It's hard to overestimate how much savings we would see if we had EMR interoperability. Like the manual hours of doing referrals to other locations that aren't on the same EMR that you're on, transportation, affordable housing, our travel nurse and our ability to recruit staff. I know it's a common pain point. And then just to echo, I think Joe spoke about it at the last meeting, but also Kim, the reimbursement, especially for our Medicaid patients. Grace Cottage is different. We actually have capacity. We have some beds and we're staffed. But when we're reimbursed for, a recent Medicaid patient at 14% of the cost of the total cost, 14% was the percent we were reimbursed for that stay. We have to be somewhere near whole to continue that effort. So we're excited about this work. I think that I think Joe said it's painful, but it's necessary. I know our board's quite engaged as well. So I just wanted to double down on those statewide efforts that we think are so incredibly valuable. And thank you, Bruce, so much for your time.
No, again, thank you for your involvement, suggestions. I know you're new to the job and everybody's glad to have you. And I need to say, I think, Grace is investing a lot in ambulatory care and mental health and other things. And this is a great example.
Ms. Sweetnam, congratulations on your position. And I had a question. What EMR are you guys on at Grace?
Cerner, we're in Community Works. So we are on Cerner, and that Community Works instance, I guess the instance is it's hosted by a separate facility. So the ability for us to make changes within Cerner, especially now that with the Oracle purchase, it's glacially slow, I would say.
In my past life, I investigated and brought fraud suits against many electronic medical records, mostly for failure to be interoperable. I'm trying to remember how many off the top of my head, but I think it was 5 or 6 since 2017, all brought here in Vermont National, but it was really focused on interoperability problems. So it's discouraging to hear that we're still having such struggles in that space.
We are, and I know that Chris, head of IT here, just when the last time we were talking, Bruce gave an example, and I won't be able to give the specifics, but basically a statewide interoperability initiative. I can't remember if it was for vaccines. Bruce, you might remember better. But in order for us to set that up, like that API, and get that, the bilateral communication going, I think the charge from Cerner was going to be around $100,000 for us. And at Grace Cottage, that's substantial. That's a substantial amount of money that we would need to pay. So I think when we look at it holistically, I do come from a health system that used Epic and hosted it internally for the health system. Just the ability to be proactive and agile, the difference is staggering.
Is the primary issue not having the same code sets or not having access to APIs, or what is the primary issue?
Oh, it's where to start. So without that interoperability, for example, when primary care, when we do referrals, to other locations within Cerner, we actually can't put in complete that entire end-to-end process electronically. There's manual papers that are getting sent over and the reports are coming back because we don't have an API to accept those results kind of back into the EMR. So you have to, accept that back in, scan it, attach it to the chart, manually, quote unquote, close out the referral. I mean, it's kind of wild. And then that example of vaccine registries, so any statewide registries, and then just improvements in terms of reporting or functionality within Cerner, just, for our nurses or for our LNAs, especially as we're trying to upskill our LNAs on the hospital side and wanting to make any changes. I don't think we've seen any changes be made in quicker than 6 months in Cerner because of the community works nature of it.
Okay, thank you. It's concerning. All right, Ham Davis.
Thank you, Mr. Chairman. I'd like to ask Bruce. The way I understand the process that's now underway is that you folks, in response to Act 167, are seeking comment from the public about these issues. My question is that it's fantastic to have Bruce's work here because this is just my opinion, but I think it's valid, that his work is orders of magnitude beyond anything that we have seen in the reform process, and I have seen it all the way from at the beginning in the middle 1980s. My question is go for it. Get all the information you can from the public. But my question is, would you consider, I'd have to ask Bruce and you, Mr. Chairman, I believe that one of the things that you ought to add is you ought to make Bruce available to the press once he gets where he's going to go in the midsummer, available to the press in a session where they can instead of giving them, they can question him about all of the stuff that he's got. That information is huge. It has the dollar number of it is already, I can just tell, if or put it this way, if that dollar number hasn't blown this board away, then you need to wake up really quickly. That's a huge amount of money. And so what I'd just like to know is, can the press have a chance to interview him and to really go over these things and in the same way that the board and the staff can interview him? Thank you.
I think in terms of the dollar amounts, they've been hitting us every single year. It wasn't this presentation or any part of this work, but maybe the last 5 years have been some pretty strong smelling salts, I think, for the state in terms of what the financial picture looks like. And with the demographic challenges we have in this state and the creation of incredible workforce strain that has, this is just a really acutely difficult time and has been, but the future looks even more challenging. And in terms of the question about availability for the press, I don't know what Dr. Hamre's schedule looks like now, but certainly I know it's chock full every single day and every single night. And I'll let him and his firm review their process for whether or not they want to speak to the press. It's not really a care board issue necessarily.
Yeah, I'll check, but I don't see a problem. I do think, as Chair Foster said, we're going to be totally consumed for at least the next 6 weeks. And clearly we need to obtain the comments from the community. We need a little time to really get to the final recommendations and make those much more hospital specific. So, let me check, but my guess would be earliest would be sometime in September. But certainly, getting information out, and as others have commented and asked questions about having everybody involved with, as accurate an information and as reasonable a prediction we can make, I think will be extremely helpful to the Agency of Human Services and the Green Mountain Care Board as they go forward with this process.
If I can just comment on that, Mr. Chairman, do you still hear me? I'm not sure.
Yes.
Are you?
Yes.
I come out of a different era, Bruce. Okay, I've spent my 10 years in covering national politics and to the federal government. Okay, and healthcare from one end of this country to the other. If you can, what I can tell you, what I'm writing in my book, if you folks can't come up with 2 hours, okay, to let somebody who's writing about it get in before September, and the reason is that September, the game is over in September, because the critical access, the critical question you've got coming up is, what are your FY25 budgets going to be for Vermont hospitals? Those decisions are going to be done by mid-September. It's over. The game's over. And what I will simply say, I think I love the work you do, but if you can't do better than that, I'm going to say that you're just not worth it. Thank you.
Thank you.
Mr. Del Trecco.
Good morning or good afternoon by now. Thanks for the opportunity to speak to the group, Chair Foster. Bruce, thanks for all the work you've done here. Just have a few thoughts in the areas of, how are we proceeding, commentary on affordability and finance, and then some transitions things. So a key message for everybody is that me and my board and our members are completely embracing this opportunity to look at everything involved with sustainability. And as mentioned in one of the slides, we'll start working with AHS to evaluate what these opportunities look like, things that are already in play, and how do we move these forward. So 3 things in that space. We need time to allow our hospital leaders to examine these recommendations. One thing that we touched on here, and it's not terribly clear to me, is the interdependencies of these recommendations. There are some really provocative thoughts, freestanding ASCs, hospital at home that's happening in some spaces, but how do these things impact one decision from one community to the next? And I think what another piece that is missing, what's the investment and the cost here, and how do you make this transition while we do this work? We also need to examine the good work that has happened at AHS that has moved forward in stabilizing some of the issues that we've been all dealing with. So if our work in long-term care continues to help stabilize our delivery system, are these dramatic changes necessary? I don't know the answer to that, but it's a question that I have. So when examining this work, we talked a lot about this today. We've got to take into account all of the things that our delivery system is dealing with: transportation, mental health, substance misuse disorder, access to long-term care. How do all these things come together to improve what we're feeling in the hospital sector? We've talked about demographics, so I won't go into much of those details. But one thing that we don't talk about in the healthcare arena, and I think it's important to recognize, is how do we grow Vermont's economy? Healthcare is a big part of that piece of Vermont's economy, but we all know we have a growing public payer line of service, and our commercial payers are declining, and that just creates more pressure. So what is that? What is our responsibility in that space? Not part of what we've talked about, and I don't know that Oliver Wyman was actually asked to do that. Moving into affordability and financials, I'm not sure of all the details in the financial models, whether other operating revenues are in or out, but one of the things that we talked about very specifically is the real inflation amounts that we're seeing around 7% versus the cap of 3.5%. I know this isn't going to be a popular statement, but providing some relief from this cap while examining these recommendations would help ease some of those challenges. Additionally, we should examine how do we maximize every single federal dollar in the state of Vermont. I'll give you one example. The state of Vermont doesn't maximize the hospital dish payment for Medicaid. We leave money on the table, and I can speak with some certainty that if we maximize that, we would minimize much of the financial burden placed on our hospital negative margins. And it wouldn't take a whole lot more money than what was spent on this engagement. Yes, it is a year-over-year investment, and I do think that this engagement was important and necessary. I'm not saying that it wasn't. So I think if we explore those state policies to maximize federal dollars, we could move a long way. And I know the intent of these proposals is to stabilize our delivery system. But as mentioned earlier by a couple of folks, we need to make sure that we don't create any unintended consequences and create multiple layers of challenges in access or our progress towards equity. So I know I said this at the last meeting, but our delivery system's constantly evolving, and maybe this is a new way of thinking, and we're coming together to look at it. But we also have to understand and embrace what we've done in the past, and look at the future, particularly the ahead model. Is that the right thing for our delivery system? Does that help sustain and stabilize in ways that we could address some of the financial challenge? I think that's important work, and we need to understand that as we move forward. So just to close, I think this is really important work. We're committed to reviewing all the recommendations, but we have to make sure we don't compromise patient safety, our workforce, and the care for our local communities. Chair Foster, thanks as always for the time here. I appreciate Bruce, you and your team, and all the effort that's gone into that. Thank you.
Thank you for attending and commenting.
Yeah.
Go ahead,
Mike, thank you very much. Learned a lot from you. You and the hospital folk clearly have a huge amount to contribute to this effort. I did try to lay out some of the preconditions in my comments a few weeks ago. Perhaps was not as detailed this time around as I should have been, but you're right. A lot of interdependencies. I think, a real reason, as you pointed out, for broad involvement, and clearly both changing, making it more possible for Vermonters to return to Vermont to get health care. I mean, given the state is sending $600 million plus out of state every year, could help the economy. And certainly, as you and others have commented, ever increasing costs of insurance, don't help. I served on the board of Blue Cross in Massachusetts several years ago, and we were wrestling with high healthcare costs in Vermont. We had the medical director of IBM tell us that IBM at the time was moving production facilities out of states that had high healthcare costs at that time to Iowa because they had much lower healthcare costs. And as for, hospitals, the personnel costs are one of their principal expenses. So absolutely agree with your points. Appreciate all the help you and your staff and advice you've given to this process.
Dr. Merman?
Yeah, thanks as well. Mr. Del Trecco, is there a way you could send the board some of the thoughts you have on how to maximize the dish payments and the financial analysis of that? That's kind of, I think, outside of the board's authority, but I think would be really helpful to understand. I think it's well outside the board's authority, but I think it'd be helpful to understand the impact to the overall system from that.
Sure.
Thanks.
Is there any other public comment? Okay, thank you, everyone, for a really thoughtful discussion and for all the public commenters that attended. I remember my first week on the board, it was pretty fascinating how many people came to express their incredible stress and concern about our healthcare system and the financing of it. And I think today, just in the public comments, we heard, in my mind, very valid concerns about the financing, right? From home health and long-term care, memory care, hospitals, primary care. I also know our insurers our local not-for-profit insurers are in incredible financial stress. So we have an amazing collection of important players that keep us all healthy and provide us care, all of whom are in serious financial trouble. And we have extremely high commercial rates, and we have challenges in making sure, as Dr. Hamre said, that we allocate the money in the most thoughtful and productive way we possibly can, which is a very, very difficult task. As Mr. Del Trecco mentioned, we don't want to cause harm in doing that. But at the same time, by doing nothing, we may be causing significant harm. And so that's why we have this opportunity to really revitalize our healthcare system in a way that is intelligent and not a happenstance of history. And moreover, that we can sustain it and that it aligns with our shifting demographics, right? So we heard about the need for memory care, incredible needs for memory care and long-term care. And as we age, and the demographics say we will be quite significantly, we want to make sure that healthcare system is aligned to those needs and that they're invested in properly to fulfill those needs for our people. So this is challenging. This is hard. Everyone here at the board, everyone that's providing care, every executive is under incredible stress because this is so challenging. But I'd like to be mindful that this is an amazing opportunity that we have as a state, and you don't get this very often. And so while it will be hard, I do think there's immense opportunity for us to get the right healthcare system that we need and that we can sustain and pay for. So incredible thanks to Dr. Hamre and Jessica Holmes for leading this work on behalf of the board, and for the legislature and the hospitals and the governor for signing this bill and working with us to try and get this right. Because I think it is the most important work the Care Board and the state have ever endeavored in healthcare. So thank you, everyone. And Dr. Hamre, thank you and your team for your time today and tomorrow and the rest of this week. Is there any old business for the board? New business? And I will move that we adjourn.
Second.
All in favor, say aye.
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 Aye. We're adjourned. Thank you. Have a nice day.